right, so welcome. And this is a way that in medical school we transmitted information from professors to medical students. And there were three ways that we did that. One was with retrospective research projects that look back on certain disease processes. The second one is prospective studies that compare the patient population involved in the study with a control group. And the third way is presenting case studies. And in this case, I think case studies are very helpful because it helps people understand whether or not indeed therapy works and doesn't work. And it's not control group, but it does give a lot of information as to what we do and how we handle sometimes very complex problems. So I'll be reading the case studies presented to me by my staff, and then I will comment on them. And of course, if you have any questions, you can write it down. And especially if you're on a YouTube visualization, you can go to hormonify.com. Info@hormonify.com is the place to put down your comments and ask us any further information. So I'll just read the case and we'll go forward. Case number one is initials AE, is a 69-year-old Caucasian woman with a history of osteoporosis on a bone scan with a T-score of -2.9 in the hip. Her doctor sent her to a rheumatologist who prescribed her Actonel. He told her to exercise and take calcium supplementation. After 2 years, her bone scan was repeated. Her T-score was worse at -3.1. Her doctor wanted to change her meds to Forteo. He told her to drink more milk. She came to us for a second opinion. AE was placed on Bhrt with special emphasis on progesterone and testosterone. Her vitamin D level was checked and was 26, which is very low. She was placed on replacement 1 year later. Her bone scan revealed a T-score of -2.4, osteopenia, no more osteoporosis. Better, but her fracture risk was markedly reduced. This case brings up certain interesting aspects of treating osteoporosis. First of all, we have had zero osteoporosis related fractures. And unfortunately, doctors who are giving drugs don't understand that you can make a bone scan look better, but not reduce the actual fracture rate. In her case, she even got worse. So the doctor told her to drink more milk because the myth out there is that calcium is a rate limiting step for bone loss. It absolutely is not. There's no studies to support it, no science to support it, and there is no calcium deficiency in America unless you have parathyroid disease. So when she came to us, she was quite upset because for 2 years she was taking a drug that knows is pretty dangerous and had risk factors. Her doctor assured her that she would be better. Of course, she wasn't. So how does progesterone and testosterone work? Progesterone in pregnancy increases a woman's body mass, especially her bone and muscle, very quickly and very efficiently. And upon recognizing that, I realized that progesterone will be very helpful in the prevention and the treatment of bone loss, whether it be osteopenia or osteoporosis. So I utilized that in my initial studies to evaluate how much progesterone was necessary. I found adding testosterone was very helpful as well. Testosterone is a bone and muscle builder. More muscle, more bone tension, increased bone density. We found that vitamin D was deficient in about 50% of our patients with osteopenia or osteoporosis. So about 15 years ago, I started checking vitamin D before it was commonly done. And we placed her on replacement therapy. It varies from person to person, but more or less 25,000 units of vitamin D per week is very, very good. And it works really well in replacing the vitamin D up to a level that we like, which is between 40 and 50. Second patient is SC, who is a 44-year-old white woman who was obese with a BMI of 36. She had been diagnosed with PCOS at age 22 when she was having irregular menses. She was placed on birth control pills and, quote, followed. At age 33, she was married and then had tried to have children for 3 years. She was told she needed IVF as she was unable to ovulate. After 3 attempts and $60,000 later, she conceived but miscarried. At that time, she was 36 years old. At 39, she had irregular menses again and was placed on birth control pills to regulate her menses. Age 44, after gaining 30 pounds, she was developing symptoms of hot flashes, night sweats, and insomnia. Her doctor said she should stay on the birth control pill, otherwise she would have bleeding problems. She came to us for a second opinion, was taken off the birth control pill, tested for hormone deficiency. She was deficient in all of her sex hormones, was placed on a balanced Bhrt replacement program. Her symptoms resolved, however, she had no children. She was placed on a weight loss program and lost 22 pounds. This is an interesting case. I remember it. And in that, doctors don't link together a history of progesterone deficiency from time woman is 14, 15. So what happens in a young woman who starts her menses? She doesn't ovulate, she's progesterone deficient. Most of the time that resolves. Women become very fertile, 15, 16. In her case, she continued to have irregular menses and at 22 was put on birth control pills with the diagnosis of polycystic ovaries. If I saw her at 18, I probably would have put her on progesterone replacement therapy until she was sexually active, needed contraception. She then developed an ovulation, which means failure to ovulate, and infertility. So again, she was at risk for developing a progesterone deficient state. So she finally did get pregnant. However, she miscarried, most likely due to a corpus luteal progesterone defect. Then she was placed back on birth control pills, which is the treatment, unfortunately, that masks the menopausal symptomatology. So she gained a lot of weight, most likely some element of depression, metabolic disorder, estrogen dominance, all of these things we mentioned in our previous lecture. You can refer back to Hormone 101. The doctor was trying to treat her menopausal symptoms or her hormone deficiency symptoms with birth control pills. Above 35, to me, that's a risky situation, as above 35 patients placed on estrogen dominant progestin therapy, that her risk of breast cancer goes too high for my comfort. So what we did basically was just place her on the balanced bioidentical hormone replacement therapy, and her symptoms resolved and she felt better. And we then helped her lose her weight that she gained from the long time that she was on estrogen dominance, and then the long time that she was progesterone deficient. And also her nutritional status was at that point very poor, and she had lost most of the weight that she had gained. The third patient is RT, a 58-year-old Caucasian woman who was diagnosed with stage 1 breast cancer at age 50. She had a lumpectomy, received local radiation therapy, was placed on tamoxifen for 5 years. She suffered from severe vaginal dryness, hot flashes, inability to have sexual intercourse, and her bone scan showed osteopenia. She had not had sexual intercourse with her husband for 4 years. Her hormone panel showed lack of all 4 classes of hormones and was placed on BHRT with a special emphasis on her estrogen level. She was monitored very closely. Her estrone estradiol levels never went above menopausal levels. In spite of that, her symptoms resolved, her sexual function returned, and she is free of breast cancer. Suzanne Summers did a wonderful job years ago in explaining the value of progesterone therapy in reducing breast cancer recurrence. I've taken it to the next level, and that my levels are much higher than she gets with her creams. However, the concept is absolutely correct. Next patient is DR, who is a 43-year-old Black woman who never had children. She was placed on birth control pills at age 19 when she developed irregular menses. Every time she tried to stop her birth control pills, her menses did not return. She reported hot flashes, dry vagina, and serious mood issues. At age 34, her doctor told her she was too young to be menopausal, even though she said to her that she felt that way. She was sent to a psychiatrist because she was insisting there was something wrong with her. She was placed on Wellbutrin for depression and Xanax for anxiety. She was placed on Restoril, a sleeping pill. She felt miserable, fatigued, had no sex drive. We saw her and her hormone panel show complete lack of sex hormones. Her vagina was so dry she needed to use lubricant just to walk. She was properly replaced and all of her symptoms went away. Her diagnosis is and was premature ovarian failure. I have seen women in their 20s who were told that there must be something psychiatrically wrong with you because they complained of, quote, menopausal symptoms. And all of them were mistreated and treated by psychiatrists for years. Some of them were so distraught and so felt attacked that their mistrust in medicine and physicians was so high. Sometimes it takes a lot of work and also therapy to help them because they exhibited signs of what we call post-traumatic stress disorder from the way they were treated. It's really a shame that after all these years of scientific research into bioidentical hormones and into chemical evaluations via lab work, that we still are treating women as if we were in medieval times. When doctors don't understand something, they right away say, well, you must be crazy. Doctors do not take time sometimes to research and study and just believe in the patient. The patient most of the time is correct in how they feel. They know their bodies, they know how they feel. Just check their levels, and evaluate them scientifically like we evaluate diabetics. We don't tell a diabetic you're crazy because you can't think straight. If your blood sugar is 700, you can't think straight. So I think this brings back from the 1940s and 50s when diabetes was treated basically as a psychiatric illness. And it's really a shame. It makes me feel good that we're able to help her through and basically reaffirm who she was as a woman, but also to get her off her poisons that she was taking for a diagnosis that was hormone deficiency. So that was very rewarding for us. And we have unfortunately see patients like this almost every week, where they're misdiagnosed and then blamed for the fact that they're not better. Next patient, AG, is a 46-year-old who had severe hair thinning for 6 years. She went to a dermatologist who placed her on a hair replacement program with no results. She was never told she might have hormone issues. She came to us for a second opinion and was found to be in severe hormone deficiency. After 2 months of replacement, her hair started to grow back, and after 6 months, she had much improved. So this is a very common complaint, hair loss, hair thinning. The hair itself is thin, plus actually losing hair. And unfortunately, most doctors do not understand the value of progesterone in proper hair growth and hair thickness, but also the value of testosterone in keeping a woman head of hair basically satisfactory. There are a lot of factors to hair loss, and surely not all of them are due to hormone deficiencies or out of balance. But it's again, what I referred to last time is what's left syndrome. Without treating them for hormone replacement therapy, regardless of the other symptoms, you're missing the boat. You have to take care of their hormone status first and see what's left. Yes, there's a lot of reasons why women lose hair growth, hair itself, and reducing hair growth. But almost all the cases, giving them the proper hormones, especially progesterone, is helpful. How do we know that? Well, every woman who's been pregnant knows that during their pregnancy, especially second, third trimester, where it's progesterone dominant, hair growth is substantial, hair thickens. Women do not complain of hair loss. In fact, they say the hair never looked better. So as an obstetrician for 30 years, I've heard that thousands of times. And so I utilize that information to incorporate that into the program because progesterone does increase hair growth given in the proper amounts. Now, we don't use the same levels of progesterone that we do in pregnancy, so they don't have maybe as quick a result, but we definitely see much improvement in almost everyone. It's very difficult sometimes because we may have a multifactorial situation. So we have to evaluate their lifestyle, other things that go on in their life. And sometimes it's familial. We have patients who said their mother had the same problem, their grandmother had the same problem, but we still feel we should give them the hormones they need for a lot of reasons, but also to help their hair. All right, next patient, SI, was a 49-year-old Latin woman who was told she had fibroids and needed hysterectomy as soon as possible for bleeding. We saw her for a second opinion, where she was found to have multiple small fibroids and an endometrial lining of 9 millimeters, which was previously biopsied and was not cancerous. Her hormone panel revealed excessive estrogens and no progesterone. She was placed on a predominantly progesterone testosterone program. Her bleeding resolved, and within 9 months, her fibroids were shrinking. She never did have that emergency hysterectomy. When my practice really was centered around preventing surgery. We had hundreds of patients, probably 1,000 patients over the years, who was placed on progesterone therapy to shrink the fibroids. Unfortunately, most doctors don't even consider that because they want to do the surgery. But when it fails, then unfortunately you have to do surgery, but at least you've done everything you could to eliminate the risks of surgery in a patient with fibroids. So once fibroids get too big, unfortunately, and they get their own blood supply, it's very difficult to actually make them go away. They may shrink down, they may be manageable, especially if there's no pain. But most bleeding from fibroids can be resolved with hormones. So we try our best to evaluate the patient and work with them to get them through the first 3 to 4 months. And that's how long it would take usually to help with the bleeding associated with fibroids. Too many hysterectomies are done out of fear that the doctor says, if you may have cancer, and if you don't have this done, you're going to die from cancer. Well, if you do an endometrial biopsy and you follow along very closely, the lining, the chance of it being a cancer situation is almost zero. In our practice for 25 years, patients on progesterone-based therapy, I've never seen an endometrial cancer, not one. So again, estrogen dominance, which is a very common abnormality, does produce thickened lining. Doesn't mean it's cancerous right away, but if it's left untreated, left unchecked, yes, atypical cells can develop, and yes, you can have an endometrial cancer. So prevention of endometrial cancer, which is what we do, would rely on changing the ratio of progesterone to estrogen to a normal balanced situation. So unopposed estrogen, which we see in estrogen dominant women, will increase the risk of not only uterine cancer, but also breast cancer. Okay. LP is a 52-year-old Caucasian woman who came to us with terrible feelings of despair, fatigue, depression, and excessive hair loss. She'd been on the pellet for 18 months. She complained to her hormone doctor of her symptoms, and he said that she needed the pellet every 2 months instead of every 3 months because she did not have enough testosterone. She complied, and she felt great for about 3 weeks. Her symptoms came back even worse, and she felt that she wanted to die. She came to us in desperation. Her testosterone levels in the male range. Her free testosterone was 59. Her progesterone was 0. Estrogens were very low. She was placed and balanced without additional testosterone. After 3 months, her testosterone levels finally came down, and we added testosterone to her program. She was placed on supplements for her anxiety and lack of energy. She said she felt great after about 3 months of therapy. Unfortunately, her male pattern baldness that she had received from the excessive testosterone had not gotten better. She said she'll be going for hair transplantation. I'd say about every week we have a patient who was on hormone therapy as it relates to the pellet. And almost consistently, when we check them, their levels are off the charts. And their other hormone levels are deficient. So I always say that pellet therapy, which I do not do, I don't recommend it, is a failed technology that does not give you, like they say, a daily dose that is consistent throughout the 3-month period. So they don't check levels very often. And if they do, they don't check the levels they need to check, because it will show that basically you're getting a tremendous amount of testosterone, and that's it. That's not balanced therapy. It'll make you feel great for a while, like this patient did. But overall, unfortunately, most of the time, the patients crash. And when they crash, the testosterone level falls dramatically. And their answer is, as this patient received, that you should just take it more often. Not only is it an incision in your back, but also it is expensive. So if you do a pellet every 2 months, that's 6 pellets a year, that will run you about $2,400 just for the pellet therapy. Now, some doctors are responding to that because they know the problem exists by adding a progesterone capsule and also adding an estrogen cream, trying to give the levels at least some semblance of balance. The trouble with both of those things is that, number one, they're expensive. And number two, the estrogen levels never get high enough to help with balancing. And the progesterone level peaks because it's a capsule, and then it troughs down by the morning. So it's not the balanced long-term management that we get with, for example, the troche form. For those of you who know us, for those of you who have seen the previous video, we had relied on the gel-based troche form, or the wax-based troche form, which is a square that's put into the cheek of your mouth, and it dissolves over time, sometimes 30, 40, 50 minutes. And that gives you a relatively good level in the bloodstream that then is free from being cleared from the liver until the second go around. So we find that to be the most effective and cost-effective method to deliver the 4 groups of hormones, which, as you know, is progesterone, estrogens, testosterone, and DHEA. We had a patient today who had a severe deficiency of DHEA. She said, my doctor knew about it, he checked it, but didn't know what to do about it. She was fatigued, and she said she's had many, many years of fatigue and low energy. and tried supplements over the counter. We do include DHEA in our formulations on almost everyone. DHEA, dihydroepiandrosterone, is a precursor to the other sex hormones. So we find it very important to replace that and to give the patient a better chance of having normal adrenal function, which is so important in the endocrine, immunological systems, and also neurological symptoms. So a lot of foggy thinking comes from not only progesterone deficiency, but also DHEA symptomatology. So I think I've finished with my case reports, and I hope you enjoyed it. And we are asking for recommendations for our next video. If you could send it in to us, and we will pick one out. And in 2 weeks from today, we will do our third in our series. We'll probably continue doing this to help educate our patients and our potential patients to weather the storm out there of what's going on in the hormone arena. Thank you very much, and have a great day.